Hello, good afternoon, everyone. I would like to welcome you to the third series of EPOS webinars. This is actually the last webinar of this series, and I'm sure that you will all take great advantage from it. We have an outstanding faculty from all over Europe. So we will have Javier Downey from Spain, and he will talk us about there is a limb length discrepancy. Is surgery needed? So it's a hot topic. Do we still respect some previous rules like the 2 centimeter rules and others that we have learned? And then we have Zagorka Pejin from Paris, and she will tell us about if the one option fits all limb length discrepancies. And finally, Christoph Radler will enlighten us about the paradigm shift on limb lengthening. Do magnetic nails have changed things for patients and for surgeons? So I think this will be a very interesting webinar. I would like to thank NuVasive for their support to this webinar and for other EPOS activities. And we shall start. In the end, we'll have a discussion. We want it to be lively. You can put your questions in the Q&A in the webinar platform, and we will address them at the end of this webinar. So please, there are no stupid questions. Every question is welcome, and I think we are ready to start. And I welcome Javier Downey to tell us about needs for surgery in limb length discrepancy. Thank you. Good afternoon.
Hello, Christina. Thank you for your kind invitation. I'd like to thank the EPOS webinar committee for inviting me, and especially you, Christina, for having me. Well, we're starting off with this first question. This first talk is surgery needed with leg length discrepancy? Well, if you don't want to sit through my whole talk, want to have some coffee or some tea, maybe I can just sum it up for you and just tell you that maybe. Okay. What are the treatment goals of any limb length equalization treatment? It would be to have limb lengths of equal length, lower limbs of the equal length. That good result is established at anything under 1.5 centimeters. Normal alignment and adequate strength and function with a total absence of pain. So these would be our goals that we're looking for with any treatment that we do to equalize any limb length discrepancy. Classically, we would say that we would start treatment after 2 centimeters. This table here that was published in a paper by Nichols et al., they point out that 2 centimeters is where you start treatment, also in Tyen's book. So we have always seen this all over the place. And, you know, you get to think, where did we get this, you know, what we call the 2 centimeter rule, which Christina talked about just a minute ago? Well, it all came from this landmark study by Richard Gross, in which he reviewed everything and referenced a paper by Rush et al., where they studied back pain in soldiers. And they found that there was no real attribution of this back pain related to limb length discrepancy. Also, Tyen did not find any amount of discrepancy related to the disability. But however, Blount does state in his paper that limb length discrepancies of 1 centimeter should be treated if there is disfigurement or discomfort. Gross in his paper states that anything less than 2 centimeters of leg length discrepancy requires no treatment. But however, he does state in his paper that attributing disability to a certain amount of shortening is oversimplification, and he recommends to not use a rigid approach, but to consider what he calls soft variables. So I would like you to point out these two last points in this for later when at the end of the talk I'm going to give. And in summary, we can say that his paper, below 2 centimeters, there's no problem. Greater than 2 centimeters, there's a considerable variation of disability. And however, there is no critical amount at which one or another treatment is indicated. In Deborah Stanitsky's paper, where she outlines a guideline for treatment, states that it recommends a lift from between 2 to 2.5 centimeters. Shortening, albeit epiphysiodesis or femoral shortening, for anything between 2 and 6, and anything greater, any discrepancy greater than 5-6 centimeters, she recommends a lengthening. In the literature, we all know, we have all reviewed this, that only 10% of the population does not have any leg length discrepancy. 2/3 of the population can lead a normal life and have a discrepancy of up to 2 centimeters. Kaufman evaluated this, he studied this, and saw that there's no gait asymmetry associated to discrepancies less than 2 centimeters. Bave, he reviewed the patients that were lengthened by the Baltimore group, the Rubens Institute group, and saw that there was a normalized stance time asymmetry after ling equalization surgery. And what are the consequences of having a discrepancy? Well, in the longer leg, the femoral head coverage is diminished, and also there's that allows a less weight-bearing area is decreased, and there's larger loads that are on the longer leg, which could lead to osteoarthritis of the hip. Also, discrepancies have been related to osteoarthritis of the knee and back pain. But really, there's nothing that tells us that we have to do this. There are no long-term studies that can tell you that you can prove it. No, this really, of course, all these things I pointed out worries the parents of our patients, because they have a discrepancy, they're young, and what's going to happen with them later in life if we don't equalize those limb lengths. But really, there is no evidence to back up these statements. There are some studies that say that in children with long-standing leg length discrepancy, it may cause permanent changes to the lumbar spine biomechanics and predisposing these patients to future low back pain and degenerative scoliosis. Also, children do have some compensatory mechanisms that we all know, like ankle equinus or knee flexion, that can alter these joint mechanics and in the end develop osteoarthritis. What are the indications? Well, there's no one-size-fits-all approach to the equalization of discrepancies. The treatment indications should take into account the surgeon's and the patient's preferences and associated pathologies. And since many lengthening devices are quite costly, affordability of the elected treatment should also be taken into account. Before indicating a treatment, especially in lengthening and epiphysiodesis, you have to determine the cause of the discrepancy and what type of Shapiro pattern it will follow. Fortunately, most of these discrepancies will follow a pattern type 1, and that can be predicted with whichever method you prefer. When treating growing age children, especially in congenitals, it's a good idea to set out a roadmap of what you're going to do at what time, at what age. So, like at first, you do all your reconstruction surgeries, and then you start your lengthenings, and you may even end up lengthening and shortening to equalize limbs at the end of his childhood. So classically, we can say that a shoeless are recommended for discrepancies under 1.5 to 2 centimeters. We can perform shortening surgeries like epiphysiodesis between 2 and 5, lengthening between 5 and 20. At the greater amounts, they're we probably combine lengthening with shortening of the longer leg. And anything above a 20 centimeter discrepancy, we would have to perform a amputation and prosthetic fitting. So let's analyze this. Okay, so shoe lifts. Shoe lifts, fine. They are good, but up to 2 centimeters. More than 2 centimeters, they're not cosmetically accepted. And we must consider also that shoes with lifts are not very desirable by the general population, especially in women who like to wear these torturing devices called high-heeled shoes that cannot accommodate shoe lifts. And larger than 5 centimeter discrepancies, if you're going to use a shoe lift larger than 5 centimeters, you do need to use an AFO for stability of the ankle. Epiphysiodesis is very low morbidity and very few complications, but timing is crucial, and you have to have adequate growth remaining to perform it. Also, it is not accurate, and as we've said before, a good result is considered as if at the end of growth there is a discrepancy of less than 1.5 centimeters. You do have to consider that you are operating on the longer healthy leg because most of the causes that cause discrepancies cause shortening, not over lengthening. Height is a big problem because you are shortening the patient. So you should consider the height of the patient. You have to have at least, the patient must be in the greater 50th percentile of height. And in a classic study by the Journal of Applied Psychology, found that people that make almost $800 more per year per every inch above average height. This is not always true, since the person standing next to me in this picture has a much larger salary than I do. In the POSNA webpage, if you look under discrepancies in their doctor education section, they state that lengthening is a procedure of last resort and is reserved for those situations in which other methods of correction are inappropriate. We can say we can safely lengthen in one lengthening treatment up to 8 centimeters in femur and 5 centimeters in tibia. And what devices do we have to do this with? Well, we have the classic external fixator. Well, of course, we all know that these are filled with obstacles, problems, and complications. PT is pretty painful. The device is very unsightly. And at the end of treatment, you leave the patient with very uncosmetic scars. We now have intramedullary lengthening devices that are really fantastic because they ease physical therapy, they reduce the pain, it's the overall better tolerance of the procedure, and at the end of the surgery, well, the cosmetic appearance of the scars are much more, which make much more tolerable, which makes it much more appealing and appetizing for patients and surgeons. However, do not forget, they're still filled with problems, obstacles, and complications that we had with the external fixators. And also has complications that are specific to the device, like in this case, the bending of a nail during the distraction phase in a non-cooperative patient. This nail had to be exchanged. So I think we can all agree that any leg length discrepancy above 5 centimeters should be treated by lengthening or a combination of lengthening and shortening. And we would also encourage patients to use a shoe lift for discrepancies less than 2 centimeters. But however, what should we do with the middle group? What do we do? Should we be performing inaccurate surgeries that have no guarantee of total equalization? Or on the contrary, should we indicate a surgery that has much more morbidity and potential complications than a simple epiphysiodesis? And also, going back to the shoe lift group, should we condemn a patient to using a shoe lift for the rest of his or her life and not do an accurate intramedullary lengthening surgery? We are at a time of a great paradigm shift with the advent of lengthening nails, which are great and have much less complications than traditional devices. So I pose to you this question: should we start indicating the lengthening at shorter discrepancies? For example, this is a case of a patient with right fibular hemimelia, which caused a discrepancy and we lengthened, and the patient was left with a minor discrepancy, but did not want to continue lengthening as he was fed up with lengthening with the apparatus. So we just left it at that and it was fine. And the patient went on well, just using a small lift. However, we have this other patient. She had a fibular hemimelia on the left leg, and it was only like 2.3 centimeters. So we're right there at the shoe lift treatment area. But they heard about lengthening with a precise nail. So that was offered as a treatment. They actually demanded that treatment. And she went on to completely equalize her limb length, and complete consolidation is at present. We did the removal of the nail, and at present is doing a complete normal life. So I think I would propose to not have any strict cutoff points where one treatment is valid and another one isn't, since the indication and the choice of a leg length equalization method are always elective and decided by the informed patient and should not be fixed by any rigid guideline treatment. The indication and a lift in the lower leg length discrepancy seems reasonable, as well as lengthening in the larger discrepancies. But do not, and also I think in the middle, we can discuss with the patient and parents what are their objectives, what are their goals, and what treatment would be more adequate for them. I think we should negotiate with the patient what to do here. But do not forget that bone lengthening will remain a challenging technique. It requires significant experience and control, especially controlling potential complications derived thereof. So in conclusion, in answer to the question, is surgery needed? We can say that for discrepancies of less than 2 centimeters, it may not require any treatment in the absence of symptoms, or maybe just a lift to equalize the lengths. And for discrepancies larger than 2 centimeters, we can say that maybe surgery is needed. But what procedure? We can offer them the array of treatments that we have already gone through, probably shortening for smaller discrepancies in patients who cannot afford the lengthening devices. And we would go for intermediary lengthening nails or ex-fix lengthening, depending if it has associated deformities. Since ex-fix is much more versatile for deformity correction than the lengthening nails, we would probably go for that if there's more associated deformities. Thank you very much, and I pass you on over to Dr. Zagorka, who will give us her talk.
Dear colleagues, I would like to thank EPOS for inviting me to this webinar, tackling an exceptional subject for me, the lengthening of the limbs. Here are my disclosures. As you know, we currently have multiple techniques and hardware available for mechanical bone guidance, such as hexapod frames, traditional reserve ring fixator, monolateral external fixation. All of them can be combined with internal fixation, and finally, the intermedullary lengthening nails. As mentioned, the successful lengthening depends on careful preparation. Clinical examination is the first step that will help us determine the discrepancy and any associated deformity, etiology, and psychological profile of patient and his family. And most importantly, it will permit us to assess the whole orthopedic problem that will allow us to adapt the surgical technique accordingly to the problem. In the case of 10-year-old girl with Ollier disease who presents a leg-length discrepancy estimated at 13 centimeters, associated with a critical varus deviation, we could imagine a variety of possibilities. First, lengthening and simultaneous correction of the deformity with an hexapod external fixator. Then stage intervention started with a distal femoral correction osteotomy and probably associated with the contralateral epiphysiodesis to reduce the discrepancy, and later on lengthening with an anterograde nail. Or in the end of the growth, we can perform a retrograde lengthening nail. We have decided with the patient and her family to perform a stage intervention. The valgus correction osteotomy improved the function for the moment, and the contralateral epiphysiodesis reduced the discrepancy to 9 centimeters. Then at age of 13, we performed 8 centimeters lengthening with a motorized nail. It is important to remember not to hesitate to perform a contralateral epiphysiodesis when the child length permitted. Here is the case of 13-year-old female patient presenting CFD valgus deformity with closed growth plates and LAD 6.5 centimeters. Classically, because of joint instability, lengthening is done with external fixator, which can result, as you know, in scarring, pin site infection, etc. The alternative treatment could be a retrograde lengthening nail that would let us address the correction of the valgus deformity using the Baumgart reverse planning method to restore and maintain a normal mechanical axis during the lengthening procedure. In this case, it is mandatory to perform the physical therapy and splinting during the lengthening procedure. Another patient with a similar deformity and discrepancy, we started the follow-up earlier that allows us to correct the valgus deformity with 8 plate and then address the length discrepancy with anterograde nail at age of 15. This way, we have avoided to transpass the knee joint. Even that the lengthening with the nail is a safe technique with the lesser complication than the external fixator. In some cases, like here, when the femur is short and the medullary canal is narrow, the retrograde reaming will fragilize the inner cortex of the proximal part, and the freehand locking technique can fragilize even more the bone, risking the pathological fracture, as it happens exactly here at day 10, and I had to fix it with the plate. Anyhow, the patient in the end had a good result. Here is the case of 11-year-old with premature growth plate arrest with an expected LAD of 9 centimeters and associated varus and flexum deformity of the femur that resulted from a septic knee arthritis at age of 3. Since we had this fracture over the nail, we decided to perform a 3D planning of the surgery using the Baumgart method. And this analysis made us realize that the deformity is much more complex and the use of the retrograde nail is at risk of fracture over its tip, as you can see here. So we found that the optimal solution is a 2-stage surgery. First, we perform a distal femur osteotomy using a patient-specific guide obtained from our 3D preoperative planning, where we anticipated the position of the future nail. And after the consolidation, we removed the plate and we performed the lengthening with anterograde nail. And the same moment, also, we performed the contralateral epiphysiodesis in this patient. The Baltimore team noted that the anterograde nail inserted to the great trochanter with the careful surgical technique may be utilized in skeletal immature patients without increase the risk of AVN of the femoral head. And also you should remember that lengthening over the anterograde nail could induce modification of the mechanical axis, especially in the important lengthenings. And in this case, you should use the retrograde nail, which is also used in associated deformity correction. In this case, the growth plate of the distal femur should be closed. In the case of the severe LAD, like here, amputation could also be an option. But however, when the family decided otherwise, lengthening program should start early. In this case, the solution to perform the lengthening at this age would be spanning joint X-fix, like here. So we fixed the knee and ankle joint during the lengthening and correction of deformity. For the lengthening with complex deformity correction, like here in severe glute disease, the best solution is the Hexapod X-fix. And the Vienna's team noted that Hexapod external fixation allows a better correction of deformity than the other external fixators. To sum it up, the hexapodal fixator can be used in all ages and pathologies and allow us a better correction of deformities. But as you know, the main problem is the pin track infection and joint stiffness. There is also a monolateral external fixator with the Verona method, which are well known, and they allow weight bearing, and after dynamization, they improve bony healing. With this fixator, you can span the joint, as you can see in this patient that had septic hepatitis at age of 3. Here is the second lengthening in this patient. This way we can protect the joint during the lengthening procedure. Also with this external fixator, you can correct a simple deformity, as you can see on your left side, extemporaneously during the surgery. Or the correction can be done progressively using this small piece on your right side. The main problem with this fixator is the fracture of the bony callus after removing of the fixator. And to prevent this problem, you can use the associated internal fixator, or you can wait and perform the lengthening with the motorized nail in older age. You could also use for the lengthening of the tibia a T of Garch, like we did it in this old case, the patient with the congenital posteromedial bowing of the tibia with the discrepancy of 5 centimeters and deformity, valgus deformity, and we obtained a very good correction of this deformity. So the monolateral external fixator is suited to all age and pathologies for simple lengthening or in case of minor deformity, especially in young patients. And the learning curve with this fixator is short. And as all external fixator, if necessary, the joint can be breached. Compared to circular external fixator, is more readily accepted by the patient, and the infection rates are lower and the range of joint motion is much better. However, with this fixator, the secondary malalignment during the lengthening is more frequent, and the risk of fracture after its removal is a bit higher. Here you can see the same deformity that I have showed you earlier in congenital posteromedial bowing of the tibia. And nowadays we treat this deformity with the motorized nail, but we have to wait the growth plate arrest. The idea to associating X-fix to internal fixator is to reduce the time of the external fixator and thus reducing the rate of complication. Lengthening over the elastic medullary nail is especially good idea for the young patients. It reduces significantly with the time of external fixator and prevents a callus fracture after the removing of the external fixator. This young girl with very important deformity and discrepancy in early disease had this lengthening of the tibia with this technique at the age of 9. And it is important to bend the elastic nails just distally to the osteotomy. And with the progressive gliding of the nails, It will stimulate the bone formation. It will permit us to remove the external fixator early. In the same time, we perform the contralateral epiphysiodesis, and we do this reduced discrepancy for 3 centimeters. And then at age of 12, she had 8 centimeters of lengthening of the femur with anterograde nail. And finally, we equalized the limbs after 5 centimeters tibial lengthening with the nail. Now she has a good joint mobility. And of course, she was more satisfied with the lengthenings with the nail. So in conclusion, the successful lengthening depends on careful preparation. The range of techniques available increase with the age. Example external fixator allows more precise lengthening with simultaneous correction of the deformity than the other external fixator. The complementary internal fixator reduces the time of external fixator and like this reduce complication and while improving the functional and anatomical results. And finally, the motorized nails are a revolutionary solution that have improved quality of the life and should be used whenever it is possible. Thank you for your attention. And now I will introduce Professor Radler from Vienna.
So thank you very much. I will share my screen here. So it is my task to talk about the paradigm shift and a little bit about the do's and don'ts of limb lengthening. These are my conflict of interest. Now, intramedullary limb lengthening really evolved with new implants. First implants were quite complicated, sometimes mechanical implants that were not so easily controllable. Newer implants are controllable, they can be reversed, and they are available now in smaller diameters, which is especially important for us being pediatric orthopedic surgeons. Now, we know very well that the intramedullary lengthening is preferred, well, much more than the external frames. We have a better range of motion, we have less pain, and we have better scars. This has been shown very nicely in a study already in 2015, and also a more recent study in 2022 showed that the quality of life is generally better for children undergoing lengthening with internal devices. Now, if we think of pediatric orthopedics, there's a couple of things we need to consider. It's the bone diameter, it's the apex, and the amount of deformity, if there is a deformity, and of course the status of the growth plate. We know from the study, and you already saw this citation before that, if we use the antegrade trochanteric approach, it's pretty safe from the age of about 8 to 10 years, maybe more 8 in girls, more 10 in boys. Nevertheless, in the tibia, we don't want to use a nail. We don't want to go through the growth plate before physial closure or close to skeletal maturity. A big change was the different nail designs and the smaller nails that now go down to 8.5 millimeters. They really allow us to target a younger patient population. In 2022, we published our first results in pediatric patients with the lengthening nail, specifically using the precise nail with a follow-up of 12 months. And we looked at the complications and some specific parameters. And I want to share with you these results in regards to do's and don'ts and what we learned from these results. So you can see we included 76 patients with 84 nails. The mean age was 16 years, but 62 of those patients were under the age of 16. When you look at the diagnosis, we did see quite a lot of post-traumatic shortening, quite a lot of hemihypertrophy, but also congenital limb deficiency. If you think about congenital limb deficiency, we need to be especially careful, as you've already heard in the prior talk. There is a big risk of subluxation, of dislocation of joints. And so even if you do an antegrade lengthening, like in this case on the left side, you can see that the lateral joint space can get close, so you need to cut the fascia ladder. You need to make sure that you do a good physical therapy. You need to use KHFO or even a brace that goes up to the hip. And you need to address instability. You need to do maybe a super hip before. You need to do a knee reconstruction, like a super knee, to get the knee stable before you do your lengthening. So what's another important thing to do? Preoperative planning. For this, you need precise and reproducible x-rays. And this can be pretty difficult. So you need to make sure you have a magnification marker, that the leg discrepancy is equalized by blocks, and then you want to do all your limb analysis and limb alignment tests that you would do for all cases of deformity. For the pre-op planning, it's nice to use templates if you have those. So otherwise, you can still use PAC system. You can measure where you should place the entry point, and of course, you need to know about the nail diameter, the type of nail, the length of nail before you start. You already heard about the reverse planning method, which we always use for retrograde lengthening, which is a very nice way to make sure that you end up with a good mechanical axis at the end. Now, what else did we find? If we looked at our patients, you can see that 37% of our patients had prior epiphysiodesis. And this points something else out, which is very important. So if you follow your patients, you want to make sure that by the time they need a lengthening nail, you can use an antiquate approach, because that's just a simpler surgery. The other thing is you might want to stop the other side and want to do an epiphysiodesis. Another thing we saw, 37% of our patients had prior external fixation. This is also important if you think about antibiotic use during surgery and in the first couple of days after surgery. We did 57 cases with an anterograde approach, and the reason for this is very simple, because it's a really minimal invasive approach. And you can see in this example, you have 1, 2, 3 cuts about 1.5 centimeter and 2 more cuts for the distal locking. So this is really a minimal soft tissue trauma. You don't go through a joint, and it's only a 1 bone segment. You usually get good callus formation. There is a tendency for some varus instability sometimes, and I'll address this later. Now, the goal of all our lengthening is to get an equal leg length. And you can see we did a lengthening from 14 millimeters to 8 centimeters in these patients. And we didn't achieve our goal in 2 patients due to complications. And we were within 5 millimeters in 91% of our patients. But still, this leaves a couple of patients where we were not really able to get a perfect match of the leg length. So this can be difficult. It's due to x-rays, it's due to the way the patient is standing. So you all things, the distraction gap, the end of the nail, you need to check all those things to make sure that you come as close as possible. We did see some complications. This is the problems, obstacles, and complications. As we also use it for the external fixation. In the nails, we did see like some problems with the old nails, with something that we call the crown fracture. In retrograde nails, we had like 2 pseudotroses that needed a revision, and we had 1 problem of joint subluxation. But generally, we were quite happy with the results of the antiquate nail. We did see some change of the CCD angle. So some of our nails went a little bit into varus during lengthening. So that's something you need to consider if you look at your results. And that's also something you need to consider if you look at the amount of lengthening. Because if you get some varusation, you lose some length. You lose a couple of millimeters. So that's just something you want to know and want to look at. For the retrograde nails, we were quite happy with the results. We had a good correction here due to a good preoperative planning. In some cases, like in this case, it was less about lengthening, more about deformity correction. You can see this girl came late for her guided growth. The tibia was fine, but the femur still had 10 to 11 degrees of deformity. So we did a good preoperative planning, and then we used a rigid reamer, acute correction. We used the external fixation to correct the deformity. You need to use a lot of blocking screws in these cases to really lock in your deformity correction, and then you can get a very nice alignment and result. Now, if we do a long lengthening, we need to be aware of this possibility of valgization during lengthening. And like in a case like this, where we want to do 6 centimeters of lengthening, when we start out with a little bit of valgus, this valgus can get more due to the fact that we're lengthening along the anatomic axis. And in cases like this, we want to do a little bit of acute varization, again, retrograde planning, so that at the end of lengthening, we don't create valgus, but we end up with a nice axis. So what are do's and don'ts in the tibia? In the tibia, we had 16 cases of tibial lengthening, and we had 5 of those. We did see some malalignment, some not so much, some quite clinically significant. So this was also a little bit part of our learning curve. Tibias, they tend to go into procovadum, we knew about that, but also they tend to go into valgus, and you need to be very careful to address this. You can see on the very left picture, this is a very slim nail, and with a lot of room within the intramedullary canal to still move, and this is why we did get some valgus in this case. Now we try to use bigger nails, and of course we try to use a lot of blocking screws to prevent this. There is a very nice paper from the Rotsbrook group from HSS, how to place and where to place these blocking screws. So always remember, especially if you have like a small nail and a big canal, or you can use the biggest nail, but you still have a space between the nail and the cortex, use blocking screws to prevent malalignment. And of course, very important in the tibia, you need to use a blocking screw posterior to the nail to prevent procovadum during lengthening, especially if you do a very proximal osteotomy, which you might need to do due to the apex of the deformity. And it's also usually nice because this gives a good healing. You need to do a fibular transfixation, and you always need to do it distally. You also should do it proximally, and there is something you should not do. Don't use cannulated screws because they all break. So we drill it cannulated, but we use a rigid screw. We can use deformity correction on the tibia. So this is a case with a varus deformity, but this girl also had hyperextension from a recovadum deformity. So we corrected both at the same time, acutely, and we did a lengthening. This looks like a lot of surgery, and it was a lot of surgery. In cases like this, you usually want to do a fasciotomy, because if you don't, you might get a mild compartment syndrome, and then you end up doing your percutaneous fasciotomy on the first postoperative day. Like in this case, that luckily healed very nicely and returned to full function. And again, had a nice correction of the mechanical axis. So what are the do's? The do's is do a precise planning. Do use the antiquated approach if possible. Correct deformities by guided growth. Then you can use a smaller approach. Protect the joints. That's very important for all congenital cases. And beware a little bit of the tibia. The tibia is more difficult and has more possible complications and so obstacles compared to the femur. What are don'ts? Don't rush in. So don't just think, oh, this is a nice case, I need to do this lengthening because I want to use a nail. Wait for the right case, and you very nicely saw in the talk before, it was a very nice talk, there is a lot of different things you can do. So some cases are maybe just not the right choice for a nail. And don't forget the physical therapy. So it's much easier in lengthening nails, and usually the range of motion is much better. Still, especially for tibial nails, you need to do a lot of therapy. And for long lengthenings, they still need therapy because then they have less pain, they have better range of motion, and they have better healing. So what's the next paradigm shift? We are already using or looking at extramedullary nailing for lengthening in smaller kids where the canal is too small for the nail. So that's something we might still be looking at while we are waiting for lengthening plates. And we would like to see weight-bearing nails again, which would be much easier for bilateral cases. So let's see what the future brings. Thank you for your attention.
Thank you, Christoph. So I'll ask all faculty to turn on the cameras and microphones. These were great talks with lots of cases. Javier is in. So
Yes.
we do have a question for you. So what's your approach to ME hypertrophy?
Okay, so of course you do all your medical workup for that before treating it yourself and treating the discrepancy. But in this case, whenever it got to me with epiphysiodesis is that you're operating something that's healthy. Okay, it is a tool that can be used and it's fine. But if you have a congenital short femur or a fibular hemimelia or whatever, and you're treating the long leg, you could be iatrogenically creating problems there. But in a case like a hemihypertrophy, that's ideal. It's the indication for epiphysiodesis because you are treating the longer pathologic leg.
Yeah, great. I think we all agree on that. Any comments, Zagorka and Christoph, about ME hypertrophy? Christoph?
I fully agree. I think that's it's a great indication for an epiphysiodesis because you also want to think about you want to think about the proportions. So proportion-wise, it makes absolute sense to stop growth.
Great. And Zagorka, then we have one question for you. If you have any experience with distal femoral correction with an osteotomy and in combination with an antegrade lengthening in one-stage surgery.
For instance, I don't, but I think that it's probably possible. Probably I will do in the future, but using the 3D analysis and patient-specific guide. I think that it's completely possible with this technique. We showed with the patient. We had a very good alignment after the surgery. So we did it because it was not possible to put the long enough nail in the patient because the nail is 245 and there was a screws on the plate. That's why we did it two-stage way. But I think it's really possible to do in the same time the osteotomy and the anterograde lengthening. The only reason why we did it two-stage that it's impossible to put in a long enough nail in the femur.
Okay, great. Christoph and Javier, any experience with this, Christoph?
For me, if I would like to correct the deformity, which is in the distal part, so I would go retrograde. If the physes are still open, then you can use guided growth. I think the problem is if you try to correct the distal deformity with an antegrade nail, is that when you do your lengthening, you want the thick part of your nail still covered within your second segment. And this will not be possible if you come from an antegrade nail. But of course, you could combine two osteotomies, a distal osteotomy and then a proximal lengthening.
Okay, great. Then another question is if we are lengthening only one segment, how much of a discrepancy is accepted at the knee level. So I think that people are talking about how much unleveled can your knees be at the end of your lengthen. Some people will try to not to lengthen tibia and femur and just go away with the femur lengthening and leave the knees unleveled. So what do you think about this, Zagorka?
It's a difficult question. It depends if it's a boy or girl, and I try to have the same line the knees, but I can't say how many centimeters. It's a good idea because, of course, it will be completely anesthetical. But if we don't have another solution, we have to accept this.
Okay, you discussed it with parents and with the patient, I suppose.
3 centimeters on the femur and 2 on the tibia. Of course, it will be logical to perform only one lengthening. The way to have 2 centimeter difference between the knees, I think it will be acceptable. It depends on the reason.
Okay.
Cosmetically, I don't think it makes that much of a difference. Biomechanically, what I've read, if the knees are within 4 centimeters of the discrepancy between them, it's fine. I agree with Dr. Peijing that I think it's ridiculous to do 3 centimeters on the femur and 2 centimeters on the tibia when, like Dr. Radler said before, integrated lengthening of the nail of the femur with an intramedullary narrow is so much more easier and it's so much more tolerable, and that you can do the straight 5 centimeters up above, and nobody's going to really notice a discrepancy in the knees at 2 centimeters.
Mm-hmm. So yes, Christoph, you were going to say.
Yeah, if you have like a hemihypertrophy, or if the physes are still open, what you could do is you can do an epiphysiodesis on the tibia and the lengthening on the femur, so you reduce the problem basically. I mean, that's one option. The other thing is it is cosmetically, I agree, functionally it's not a problem, and I think there is a gait analysis study that shows that up to 4 centimeters, it doesn't really, you can't really see it like in the curves. But cosmetically, when you sit, of course, it is a difference. So your knees might be different, and I could imagine that some girls and also some boys might not be so happy, but I think that's very individual, and I agree it should be discussed with the parents. Yeah.
Yeah. So another question from the audience is about polio. I don't think we see much polio in Europe, but any of you may have experience as you do volunteer trips. So the question is, in a polio-affected limb with closed growth plates, would you start with lengthening and then address the joints, or would you start with arthrodesis and then lengthening? Christoph?
I mean, it's a difficult question because, you know, it really depends on the case. But for example, if you consider like an arthrodesis of the ankle joint plus a lengthening, I mean, that would be an indication you could do both at the same time. So you could do an arthrodesis at the ankle joint and do a lengthening at the same time. But I think you need to be very careful in polio. You can throw off a polio patient functionally very easily. So I think it's something that needs to be considered very, very well, and you need experience with those patients to be able to manage them well and to predict the functional outcome.
Yeah. Then another question is, I'll ask Javier to answer it. What is your lower age limit for frame correction? Because this participant feels that 6 years old is the age at which a child can cope. And they also ask if you have ever used 8 plates medially and laterally for a temporary epiphysiodesis.
Okay, so if you look at deformity correction, like for fibular hemimelia, you can do lengthening with an external fixator when you do your super ankle, for example. Although now with the West Palm Beach group, Dr. Paley's group has said that they wait 3 weeks between the reconstruction surgery and then put the frame on. Okay, so you can do lengthening. You do that at 18, 24 months.
Yeah.
Okay, so and when I try not to do any deformity correction, it would probably be between exactly the age that they say that the patient is psychologically able to cope, which is between 6 and 8. 6 and 8 is when the patient doesn't understand the aggression, or does understand the aggression of the surgery, but doesn't understand the benefit of the surgery. So that would probably be the time that I'd stay away from putting a frame on a child. Of course, there are different children that can cope differently, so you'd have to really see that. It depends. Now, with the 8 plates, that's a big debate, ongoing debate right now. The 8 plate was not originally designed for leg length discrepancies. It was for angular correction, okay? And this has been used for everything now. And now they're getting into using it for discrepancies. It can be used. Peter Stevens, as the developer of the 8 plate, has published a recent study where you can leave it in as a sleeper plate. You take the screws out, let it lengthen again, and put the metaphyseal screws back in. But I personally think that it's you can create an intra-articular deformity because you get the pagoda effect. Okay, so I would stay away from that. I would wait for longer-term studies on that, because you don't know what intra-articular deformity you're going to create using that treatment.
Okay, thank you, Javier. Zagorka, what are your thoughts? What's the youngest child that you would lengthen? And what about using 8 plates for epiphysiodesis, for temporary epiphysiodesis?
I agree completely with Javier that we don't use 8 plate because to correct discrepancy, we're afraid of modification of the knee joint. And I think that somebody, I don't remember which team showed this, but I think that it's not really a good idea. Of course, we need more follow-up from the people who are using this type of epiphysiodesis. And for the younger patient, we try to don't start very early, except when we have to perform a few lengthenings, of course. Generally, we start after age of 8. We think that we have better bony healing, the better physio acceptation with the physiotherapy, and if possible, we start later. If it's necessary, we perform external fixation, and then, as I've showed, we try to perform with nails the next lengthening. So, but in the case if we have to start too early, or sometimes we start at the age of 4, it depends.
Great. Christoph, what about you in Austria? What's the earliest age that you would reconstruct and lengthen?
I mean, I would feel pretty confident to use a frame at the age of 2 years. And that's usually an age where patients cope very well. So they really don't mind it, and they just run around with it, and they incorporate it in their scheme usually within a week. And the advantage of that age is that they heal very quickly. So the timing frame is very slow. And so also it shows the parents that this is something which is very easy, that it is something that can be done very easily. So I agree, the age 6, 8 is sometimes very difficult, because that's where children kind of realize themselves, and that's a time that can be difficult. But the young age is usually, like young age around the age of 2 to 3 years is usually well possible.
Great. So one last question, and we will close this webinar. One question about bilateral tibial lengthening. Do you stage one tibia and then the other, or do you perform both tibial lengthenings at the same time? Yep,
I'll
Javier.
take that if you want. If I guess they're referring to stature lengthening. If you're going to do bilateral, do them both at the same time, because if you encounter complications, you can stop the lengthening on the other side. Now, if you lengthen one leg and you don't have any problems, best case scenario is that you lengthen the right tibia, you bring it out to length, you're fine. And now you go back to this OR and you lengthen the left tibia, you encounter problems, you're going to leave that patient with a discrepancy. So it's better if you start off with a healthy patient, lengthen both tibias at the same time, like both femurs. You do not do them staged, in my opinion.
Thank you. So we're pretty much on time, and I would like to thank very much to Javier, Zagorka, and Christoph for their great talks and cases shown and all the tips and tricks given. And I would also like to thank EPOS for the support for this webinar and NuVasive. And we will close the session. Have a good evening. Thank you, everybody, and I hope that this was useful for everyone attending. Thank you. Good evening.
Thank you all.
Thank you.